in your HES book. So pulmonary neoplasms. Neoplasms is just another word for lung cancers. So of course, the main etiology, and we want to just get this out here right now, the main etiology of lung cancer is smoking. So just in general, this was a statistic provided by Dr. Keith a couple of years back. And just in general, 1 in 7 people will develop a chronic lung disease, and 1 in 15 people will develop lung cancer. It's pretty staggering. And then, of course, right now with COVID knocks all these statistics out of the water. But that was before. So this is, of course, a pathologist view of the effects of smoking on the body. So we know we're not going to go through all the deleterious effects, but it does. Smoking cigarettes, marijuana, vaping, of course, not good for your body. Your lungs just can't filter and process all of that extra toxins that come in. So it does deteriorate the tissues. And heavy smokers are 64 times more likely to develop lung cancer. And a lot of that is related to all of these different poisons that are in cigarettes. So it's not just tobacco itself. There's so many other chemicals that, of course, if you wouldn't just say, oh, here, let me go and smoke some arson, some carbon monoxide, some methane, any of that. So, just, of course, Joe Camel versus Joe Chemo here. It's kind of a cute picture. And, of course, none of us can identify ourselves as being old and sick. So, it's always just we make decisions at the time based on what we think is okay. But, really identifying ourselves with the long-term effects of smoking isn't something that's very common. So lung cancer is the leading cause of cancer deaths in the United States, more than breast cancer, colon cancer, all of the cancers combined. So lung cancers, it's bad. It's 15% of all cancers, 31% of all cancer deaths in men, 21% of all cancer deaths in women, but it does lead the way in deaths from cancer. And then the different types, if you look in your book on page 1054, box 45-1, the World Health Organization has a multitude of different types of lung cancer, but we're just going to classify it into small cell lung cancer. It's also called small cell or oat cell because the nodules do look like little oats. And then we'll classify it as non-small cell cancer. And then differentiating between small cell and non-small cell, the other types are squamous cell, adenocarcinoma, and large cell. So small cell lung cancer is about 15 to 25 or 20% of all lung cancers. It's the most aggressive. It has a rapid growth, metastasizes early, and the term metastasize means that it spreads to different body parts through the lymph nodes. It has a very strong correlation between smoking. Non-small cell can be squamous cell, which can be more common in men, which will lead to pneumonia and atelectasis and more obstruction in the airways. Adenocarcinoma is more identified with women and non-smokers. It can get into the mucus glands, and it can affect the cavity, lung cavity and cause pleural effusions as well. So, large cell can also be called an undifferentiated type, can really get into the pleural space as well, cause chest pain, pleural effusions, pneumonia, and then hemoptysis, meaning spitting up or coughing up blood, which can be a sign of all cancers, but can be really common in large cell as well. So smoking and lung cancer, the incidence of lung cancer begins to increase greatly around the age of 40. This is something that you guys, it's going to come up a lot. And even the second years as they're studying has kept kind of wanting to get reminded of this calculation. So to calculate somebody's pack year smoking history, You look at how many packs of cigarettes they tend to smoke during the day, and you multiply that by the number of years smoked. So take, for example, if someone smokes 1 pack of cigarettes per day for 20 years, they have a 20-pack-year smoking history. If they tended to smoke 2 packs of cigarettes per day for 20 years, they would then have a 40-pack-year smoking history. So the incidence of lung cancer increases when someone gets to a 20-pack-year smoking history. And an ex-smoker that has not smoked for 10 years will have the same risk of a lung cancer diagnosis as a non-smoker. So people need to quit as soon as possible to help their lungs. So factors, of course, smoking, but also people that have exposures to different pollutions and chemicals, like at work. So asbestos dust, radioactive substances, radon. You guys have all heard of when people buy or sell a house, they have to have or you don't have to, but it's recommended that you get a radon test because that's a substance that you can't. It's a substance that you can't detect without specific testing, but that can cause lung cancer. Miners, especially of uranium miners, more susceptible to lung cancer. And then pollution, urban dwellers, industrial exposures, people that are exposed to hydrocarbons, nitrogen, diesel exhaust, air pollution. Your book does have a lot of other ones, metals, mustard gas, there's wood dust, anything that's burning outside. So there's just, anytime you have smoking and burning together of any chemical, you have a increased chance to getting lung cancer. So once again, small cell OAT, squamous cell, adenocarcinoma, large undifferentiated, and we'll go through each type. But these are just kind of depictions. This would be squamous cell, adenocarcinoma, small cell, and a large cell. And you can kind of see how small cell is really aggressive and gets in there and takes over. Okay, so first squamous cell, it forms from the basal cells of the bronchial epithelium. It's slower growing. It's a little bit later to metastasize or spread. It's more centrally located. Adenocarcinoma, and once again, this is associated with non-smokers and women. So adenocarcinoma is more common. It starts and spreads from mucus glands of the tracheal bronchial tree. It can be usually more of a peripheral lesion. So as you can see, away from like the hilar region. It can metastasize to distant organs. It has a medium growth and metastatic rate, so quite a bit later. And then cavitations are common. So if you remember when we studied about tuberculosis, cavitations are these like pockets where the cancer, the tumors and the malignant cancers can get into and cause a cavitation or a little pocket. Of course, when you have a little pocket, there's not respiratory gases being exchanged at that area. It does, however, have a better prognosis than others. So this is a really cool slide that Dr. Keith shared last year, and it talks about non-small cell lung cancers, so squamous and adenocarcinomas. One thing that's really been helpful with lung cancer treatment is genetic factors. So they can actually get in there and test the gene of patients, and then they can tailor their disease to different types of therapies based on what the genes are. So if you can see here, this is different genotypes of different lung cancer tumors. And then with targeted therapy for, as I said, the non-small cell lung cancer, so the squamous cell and the adenocarcinomas, the tumors will shrink a lot, they will shrink, and they'll be deactivated a lot easier with specific genetic testing and targeted treatment. And then small cell or OAT cell, it's very early metastasis, very rapid growing, Doubling time of a tumor can be in 30 days, so just 1 month. Causes about 14 to 25% of all lung cancers. It has the strongest correlation with smoking, and it has a very poor prognosis. If somebody gets oat cell or small cell lung cancer, treatment, they're not resected, meaning they usually don't qualify to go in and take out the tumor. Generally, it's radiation and just any palliative care. Patients commonly relapse in 24 months. So it's the most aggressive. And then large cell undifferentiated can mean a lot of different, kind of the other, besides that, all the other types. It can be rapid growth and metastatic rate, can be found in peripheral or central regions. It can cause about 10 to 15% of lung cancer. Once again, the cavity formation is common, and this one can be treated with surgery. So pathological changes that are seen with lung cancer can be secondary obstruction, compression of the bronchi, blood vessels, nerves, which when there's compression and air is not able to get down into the lungs, it can result in atelectasis. Pleural effusions and pneumonia are very common along with the lung cancer. A lung abscess, and then metastasis. So metastasis, once again, means being spread, and it can be most commonly spread to the brain, bone, liver, adrenal glands, and to the skin. Signs and symptoms, and once again, this usually presents in patients greater than 40 years old. Patients can be asymptomatic, but most commonly they'll just start to know, or they'll start to experience a cough. They'll see changes in their cough and sputum. Hemoptysis, which means coughing up of blood, can occur in about half of the patients. They can just have this non-specific, but just like a pleural pain, like a chest pain. And then dyspnea, hoarseness with when there is a tumor that's compressing on the laryngeal nerves, weight loss, anorexia, and fatigue. So this is a big sign and symptom. So when you hear a patient with weight loss, not feeling like they want to eat, hemoptysis, those are all pretty big signs of lung cancer. Chest X-ray, by the time it's seen on chest X-ray, it's usually pretty darn advanced. Shadows can be cast by a tumor. There can be pulmonary changes with obstruction, so they'll a lot of times get infections. They may have effusions. Hilar mediastinal masses can kind of be seen before the actual tumor itself. But most common secondary changes then that can be seen on the X-ray are atelectasis and pneumonia. So here's this one. I mean, if you took a chest X-ray and you had this, it would be pretty bad at this point. Of course, this also pretty darn bad. This can be called superior vena cava syndrome, where there's a tumor that really suppresses on the superior vena cava, so blood pools and backs up into the facial and neck, in the face and neck. So you can tell with that there's a chance there could be lung cancer. And then tracheal lymph node enlargement. Before also talking about diagnostic procedures, sputum cytology, so testing the sputum, can be pretty successful. Testing the patient's pleural fluid, bronchoscopy. You can obtain a biopsy through a bronchoscopy. And a bronchoscopy is where this is something you'll see pretty commonly. And the technology for bronchoscopy is amazing now. Pulmonologists can obtain a biopsy. They can wash the lung for histology or cytology, meaning they can look at the tumor and the cells around it with a microscope. You guys will be involved doing bronchoscopies quite frequently. And then percutaneous biopsy of the lung lesion, really going in and taking the tumor out and sending it for checking out. That's a surgical procedure. And then like PET scans or radioisotope scanning of the liver, brain, and bone to see if it has metastasized. Another thing I wanted to talk about, and that is the screening. That's really been a big deal. So as we said, chest X-ray doesn't really see tumors, but CAT scans are a lot better at diagnosing. So there's something called the the National Lung Cancer Screening Trial, and it's patients who meet these criteria. So ages 55 to 74, a 30 or more pack year smoking history, former smokers within the past 15 years, and then patients having no history of lung cancer. So they've just done a lot more wider screening. Just like if you're a female, when you get to be over the age of 40, you're supposed to do a mammogram. Well, for those people that meet that criteria, having a lung CAT scan is more common practice now, and it is helping to reduce mortality of lung cancer. Here's a picture of a bronchoscopy. And so once again, here's the doctor putting down a scope. This can go down into the tracheobronchial tree nasally, and then commonly patients will have endotracheal tubes, and you can put the scope down the endotracheal tube as well. And the scope is used to view airways, check for any abnormalities. This is pretty significant. This patient has a big tumor right here in the tracheobronchial tree. So treatment could be it totally depends, as we were talking about before, what type of tumor and the genes that are involved with that. A lot of times patients can get a surgical resection, so take out the tumor. Sometimes it's too far advanced and they can't. Radiation in some patients is just palliative in nature, especially with the small cell lung cancer, and it'll just help them with some of the major tumors, but won't really be a cure. So one of the things looking at patients' spirometry, so FEV1 is the biggest indicator of patients' ability to undergo a resection. So if they've already lost a lot of lung function, so if their FEV1 is less than 50%, it's probably not a very good idea. They're probably not going to be able to withstand removing anything more than one lobe. And then pulmonary hypertension increases the risk for surgery too. And if you remember, pulmonary hypertension is high blood pressure in the pulmonary vessels. Hypoxia is also a risk. So radiation can be used, but then of course, radiation is getting better, but it can cause, when you radiate the body, it can affect other organs, the esophagus, mediastinum in general. It can cause pneumonitis straight to the lungs as well, pericarditis and myelitis. So just, really causing a secondary complication to other parts of the body. And then staging with non-small cell, you can use the mnemonic T and M. So T standing for tumor. And that's where the primary tumor is, and then, or the size of it. And then any N for lymph node involvement, and then M would be, did it metastasize? So when you have when you have 0, it's the least advanced, and when you have stage 4, it's the most advanced. So the primary tumor, as we said, look at the size, location, complications of that. Is it in the hilar or the mediastinal nodes? Is there any distant metastasis? And then characteristics of the primary tumor can be looked at through bronchoscopy, chest X-ray, CAT scan. Cell type is determined by viewing it microscopically. Cells can be viewed by sputum, by washing, or brushing with a bronchoscopy. So staging, stage 0, limited to the lining of the bronchial airways, no metastasis, a good prognosis. Stage 1, tumor is smaller than 3 centimeters with no metastasis. Stage 2 has spread to the lymph nodes of the chest wall. Stage 3, A and B, metastasis to either the mediastinal lymph nodes or chest, but no distant metastasis. And then stage 4, it has spread to the brain, bone, or liver. Treatment, once again, surgery is used as diagnosis, removal, and can even be palliative in nature. Radiation can be used in about 50% of the time. Chemotherapy can act at the cellular level to disrupt enzyme production, inhibit the RNA and DNA protein synthesis, and will interfere with the cell mitosis or the growing of the tumor. And then, as I said, there's a lot more biologics used based on DNA and more targeted therapy. So these are just final pictures of cancer developing in major tracheobronchial tree area. So here's it begins at the inner wall of the breathing channel and then spreads into the surrounding lung tubes. The blackness in the upper left indicates the large amount of smoking resulting in cancer. And this is a picture of the pharynx. It's cancer destroying the lung box or the pharynx. And that is it. So one thing I do want to show you guys it's a really good video. And that's something called a navigational bronchoscopy. Okay, so if you go over here, I want you guys to watch the lung nodule biopsy, this video right here under the lung cancer notes. And it's something called a navigational bronch. And it's really neat because it's almost like a video game. It will actually, with CT scan, map out where the nodule is. And then the doctors, when they're doing the bronchoscopy itself, as you guys remember, the tracheobronchial tree just branches out into a lot of different branches, and they get smaller and smaller, and that can be really difficult. So if the doctor can have a navigational system, it can literally, when he's going down into the tracheobronchial tree, it can tell him to take a right or a left at all the different branching. So what I want for you guys to do for this week is read chapter 45, lung cancer, and then I want you to look at those notes and just watch the navigational bronch.